Hello, friends. Welcome back to Perfecting PT. This will be my first podcast of 2026. So, for anyone who does not know me, my name is Nate. I am the owner, creator, founder, talker on Perfecting PT. I've got some upcoming guests planned that I'm really looking forward to, one of which I think will be particularly interesting. He's actually the regional manager for PRN. That's Physical Rehabilitation Network. There are many clinics that are associated with them. And I was chatting with him one day, and he has some pretty strong views on the importance of insurance-based physical therapy and rehab. So I think it'll be interesting to hear his thoughts, because a lot of people nowadays are pushing towards cash-based, cash pay independent PTs, or setting up a clinic that is more cash-based, even if there are multiple clinicians. For those of you who do know me, welcome back, friends. I'm super pumped to have you. If this is your first time, thank you for taking the time to listen. I know there's a lot of things you could be listening to, and I will do my very best to make the time that you are spending with me as productive and helpful as possible. I'll give, for anyone wanting follow-ups on previous things I had brought up, I'll kind of give you a little insights into my life right now, because it has been crazy. For those of you who don't know, my wife had brain surgery at the end of October because she had a pretty severe Chiari malformation that was making her torso and her arms and hands go numb, and she'd have intermittent, really intense bouts of pain or vertigo, and it was really, really rough on her. So she had to get surgery, and she was out of work for about a month and a half while she was recovering. So that was quite the experience. For anyone who has had a spouse that has been through a surgery, I share your pain. I love my wife dearly, but she was a terrible, terrible patient. So for anyone out there who is a caregiver of any kind, or dealing with helping a close family member with post-op, just stay strong. You're doing the Lord's work out there. Secondarily, we bought a house. And with my wife's recent surgery, she still has lifting precautions. So guess who's moving everything? That would be me. But that's very exciting. We are very, very fortunate that an opportunity fell in our laps, because otherwise we would not be able to afford a house, because it's real hard out there. Otherwise, I'm starting a side business with high intensity laser therapy through a local doctor that is willing to let me use it on the weekends. So we'll see how that goes. I'm curious to know more about that. I've been interested in light therapies for some time now, and I'm especially interested in some red light therapy because during my wife's brain surgery, I actually developed psoriasis. They think it was stress induced, but so I would love to check out light therapies and see what it has the potential to do as an adjunct therapy. And last but not least, our beautiful Saint Bernard, Daisy, who is the mascot of the podcast. She has been getting worse with her seizures, and she actually had a couple really big seizures about an hour and a half ago. So if she comes and pops in here, don't be surprised. But yeah, so I apologize that I've been slow on the draw for 2026, but we're going to get back on the grind, and we're going to start popping out episodes every couple weeks. Because we need to. I have goals of what I want to do with the podcast this year, and I want to put out at least 20 episodes. So we got to get going to make that happen. So for today, it will be a shorter episode. For anyone that has listened to previous episodes, we did longer, long form discussions. I actually did some CPGs for clinical practice guidelines, and I still have plans to do more. But I'd also like to mix in some shorter podcasts with some quick tips about how I personally treat things, or how a guest of mine may personally treat things, so that we can really get to the nitty gritty of helping us get down to business without necessarily getting lost in all the research and all the data and stuff. So for total knees today, I'd just like to share my perspective on total knees. I have seen a number of total knees, which is not particularly common for me. I more often see complex or chronic pain patients, and most of the patients that end up at our clinic are patients that have been to other doctors or have been through surgery or have been to multiple other physical therapy clinics and then didn't get better. And they are not coming to our clinic specifically because of me. They're coming because my boss, who is a tremendous, tremendous clinician, he's kind of seen as the kind of last resort for these people that haven't been helped otherwise. And so I get to be a part of that. So that's normally what I do, but lately, tons of total knees. I think I had 5 or 6 total knee evals in 1 week, a couple weeks ago. So I've really got a chance to think about why I'm doing, what I focus on, how do I progress it, and what my priorities are for these people. And I would like to share that with you today. So first things first, I generally think that people after a relatively uncomplicated total knee, I think they should get into therapy within 3 to 5 days. I think that the first 2 weeks is particularly important. For me, when a patient comes in, oftentimes they're in a walker. Rarely are they in a wheelchair. But I tell patients that these are my goals for range of motion. I want their extension to be less than 5 degrees and ideally 0 degrees or some hyperextension within 2 weeks, and 90 degrees of knee flexion by 4 weeks at the latest. Generally speaking, I want people to get to 115 to 125 degrees by 6 weeks at the latest. And something I had heard, I did not know this, and to be fair, I haven't been able to find a source for this, but it seems to be very accurate. My boss was telling me that the prosthetic design that is used for total knees is actually designed to allow between 115 and 120 degrees of knee flexion. I have not been able to find a source for that anywhere, but it tends to be true. Most total knees that I see are not pushing past 130, whether it's immediately after surgery, 8 weeks after surgery, or maybe they come follow up with me for a completely unrelated issue a year and a half later. Their knee is still generally not getting past 130. Most of the time they peak between 115 and 125. So I try to set expectations for range of motion early. I tell them 5 or less is best. 5 to 10 is okay. Greater than 10 is not great, and greater than 15 is bad. So we try to get them as close as possible to 5 or less. If someone's knee has not been straight, for extended periods of time, maybe it's years because of severe arthritis, their mechanics, who knows? If their knee has not been straight in a very long time, I don't anticipate that their knee will get straight. A lot of people that come in because they've had rheumatoid arthritis or they're really unhealthy, maybe they're obese, they're not particularly fit, and they come in and they're like, my knee hasn't been straight for years. Do you think it'll happen? I don't tell them no. I tell them that we are going to get it as straight as we can, and we're really going to push the envelope. However, if we can't get it completely straight or the knee does not want to go straight, we're at least looking for what I said. 5 or less is best. 5 to 10 is okay. It's not great. 10 to 15 is not what we're looking for, and over 15 is bad. So what do I generally do day 1? I'm going to kind of skip past the subjective portion. I mean, obviously, if you are evaluating a total knee, you need to remember that after surgery or bed rest, that there is a higher risk for clot formation. So you need to be asking about clot history and follow the Wells criteria for a clot. I will include the Wells criteria down below in the show notes. For those of you who are just listening, I'm pointing to the bottom of the screen with my finger. For those of you watching, it'll be down there. So I will include the Wells criteria. I will also include the clinical practice guidelines for total knees. I don't always, I have my differences in belief between the clinical practice guidelines and what I do practically. But that will be a conversation for another time. So first thing I do, my evaluations are very straightforward. I'm not tormenting these people, especially if they're less than 72 or 48 hours after surgery. I have even seen people come into the clinic less than 24 hours after surgery, and even sometimes same day based on their surgeon's preference. Most of the time what we're doing is we're looking at a baseline of what they can tolerate for motion. Because they are so fresh out of surgery, I'm not cranking on their knee to flex or extend. I'm simply looking at where does it go relatively comfortably, and starting there. Most people will have generally between 10 and 20 degrees of knee extension, and a lot of people end up somewhere between 40 and 60 degrees of knee flexion. That's not particularly concerning to me off the bat, because again, they're so soon post-operatively that the body is just underwent a huge traumatic response from surgery. Their implants were literally hammered into place. If you have not seen a total knee surgery, I would recommend you Google one if you can tolerate some gore. I had the opportunity while I was living with an orthopedic surgeon on one of my rotations in Gillette, Wyoming, to actually go to the OR with him, which was a tremendous experience. For anyone wondering, I called him Stan during a surgery. I had a question for him and I said, "Hey, Stan, what are you doing?" And everyone in the room froze. They could not believe that I had called the surgeon by his first name. But to be fair, I lived with him. I mountain biked with him. We hung out. We ate dinner together. Like it was pretty chill. So it was pretty interesting when I was like, "Hey, Stan, what are you doing with that hip or with that knee?" And everyone, you could hear a pin drop in that room. But if you are unfamiliar with how a total knee gets implanted, they either do cemented or not cemented. There's actually new prosthetics that are not cemented, but they take essentially a mallet and they pound the tibial plateau prosthetic into place. And then after they chop off the femoral condyles, they also hammer prosthetics up into place there. And it's pretty intense. It's essentially carpentry. So that first day, I'm looking at what their relatively comfortable extension and flexion is. From there, if they are in a lot of pain, I elevate their leg with a bolster. I do both generally if I can, if I have a bolster that can put both legs on it, with the feet elevated as well. So not just the knees elevated with hook lying. If you don't have a bolster large enough to get their knees elevated and their ankles elevated, I put two of like the half circle or the block bolsters together, because I want essentially their calves up parallel to the table and then their thighs going down and then them laying flat. If they are painful, again, I get their legs up like that and I will put tens on them. I will put tens on them with settings of 2 hertz, so 2 pulses per second, like a contraction, and I put the pulse width at 200 nanoseconds, I believe it's either nano or it's got to be nanoseconds. I can't remember, but it's 200. So hertz 2, pulse width 200. At that point, I put it on their vastus medialis right by the kneecap, and then I put it clear up high on the vastus lateralis up by the hip as high as I can go. The other channel I put on either side of the gastroc. And with their leg up, I have them turn it up as strong as they can go, but not painful, so that we can actually get, hopefully, an active muscle contraction, but just a quick pulse. I have found that helps people get their quads back firing in the initial phase. It's not going to help super well for like a tetanic or like a complete total terminal knee extension contraction of the quads, but it will help kind of getting the brain back connected to the quad and get the quads firing as well as the calves. Because if you think about it, at 2 hertz for 10 minutes, you're going to get 1,200 mini contractions of the calves and the quads together. That can create some compression and relaxation of the knee joint itself, facilitate fluid recirculation within the joint, as well as just get the body tolerant to contraction. If they are not very painful, or if their range of motion is quite good, I will get NMES. So I will get or a Russian. I'll do Russian stimulation on their quads, and I like to put them on I put them on a full foam roller under their knee, and I put it right in the middle of the quads, right at the rectus femoris, right above the kneecap, and then all the way up high on the rectus femoris, as high as I can go. I like to palpate deep with my thumb on the upper thigh, and when I find that vertical band, I try to put the pad right there. I don't like using 2-inch by 2-inch small square TENS pads for NMES. I personally think it's a waste. Is it better than nothing? Yes, but if you only have the small square pads, I would recommend setting it up on the quads and the calves. Um, what I like to do for the NMES, I like to use the 2 by 4-inch pads, the big rectangular pads. So that way we get a broad contact surface that can really stimulate a big portion of all the quads. And the NMES, for anyone wondering, we use the little Flexit units. They're gray, they're rechargeable. And I put it on the symmetrical EMS function, and I put it for 15 minutes. I put a 5-second ramp. I leave it on for 10 seconds and then have a 45-second off cycle. I set it to 50 hertz and I set the width to 300. While it is going, I will have patients perform a short arc quad. Most patients cannot do a quad set in isolation. They just don't have the neuromuscular control that early on. So I put them in a position that will facilitate the easiest success at extending the leg possible. So I put like I said, a full foam roller underneath their knee, gives them lots of room to extend. And if they still can't do that, like if it's really weak, I put them on something even bigger. I may even put their leg over a bolster so that they actually are in hook lying, so that they can get some contraction and lift with the short arc quad. So that kind of recaps most of what I would do day one as far as in the clinic. I'm assessing range of motion. I don't get too crazy with joint mobility assessment. It's so early on. I don't beat them up too much. I just give them an introduction that gives them some success with leg extension, as well as starting them on a home exercise program. For the home exercise program, it's pretty straightforward. The first thing we want to make sure is that they don't die. Okay? If PT school taught you nothing else, which it may not have, because that's how PT school is. Speaking from personal experience, if PT school didn't really teach you anything other than to have people not die, this is important. So I get their legs elevated, and I have them do a ton of ankle pumps. And I let them know that it's very important that they get their legs elevated and do lots of ankle pumps, so that while they're less active and sitting and recovering or lying down frequently throughout the day, they don't get blood pooling in their calves and their feet and beginning to coagulate. It's just, for how simple it is to prop your legs up and wiggle your feet around a bunch, it's not worth the risk. So I always give them ankle pumps. Second, I always give them short arc quads. Again, we want to facilitate success early. And a lot of patients, if you put their leg as flat as they can on the table, oftentimes they don't like it. There's a lot of strain, either pinching on the front of the knee or pulling on the back of the knee. Again, from recent trauma, and you tell them to squeeze their quads, I would bet 95% of people can't do it. And you'll sit there and you'll try to cue it and cue it and cue it. And guess what won't happen? They won't contract their quads in isolation. It will almost always have a co-contraction with the hamstrings or the glutes, and that's not what we want. For normal mechanics and for normal just coordination, they should be able to voluntarily isolate contraction in the quads, and short arc quads is the easiest way to do that. So that's to facilitate the quads, for extension, and for improved neuromuscular control. And for the hamstrings, I just like to do heel slides. I have a few variations that I really like. If they're a bit more active and they are able to do it, I have them do just a normal heel slide, actively, with a strap around their foot to give it a little extra overpressure. I don't tell them to hang out for extended periods of time in knee flexion. I tell them to pull until it gets minimally uncomfortable, 3 to 5 second hold, and then let it go back out. And I tell them to do 20 of them. I tell them to do the same with the short arc quads. I tell them to contract their best, hold for 3 to 5 seconds, and relax. We are not going for a painful push right now. We are trying to reintroduce movement in a way that helps facilitate the healing process and recovery we will get to more aggressive stretching and joint mobilizations that may be uncomfortable if they're having a hard time progressing at those milestones we talked about. Again, less than 5 degrees of extension missing at 2 weeks, and greater than 90 degrees of flexion at 4 weeks. So that's for knee flexion is the heel slides. So that's sorry, let me recap. First one is if they're doing pretty good, active heel slide with some strap over pressure. If they're not doing well, and you know the type of people I'm talking about, either they're like, oh, it hurts, or they're just unfit, they're unhealthy. I like you can just do more of a passive heel slide, put a strap around the ankle and just have them work on it. Or one I really like, if they have access to a yoga ball, I like them to put both legs elevated up on the yoga ball, and I want them to work on doing double knee to chest on the yoga ball because they can use their unaffected leg to help very easily and comfortably start working that knee through some flexion and extension. Last but not least, we do want to work on stretching into extension. We want to get the joint closing down into full extension as quickly as possible. And we also don't want to give the hamstrings and calves time to guard, which would also prevent extension. How do you know which is which? I often find that if people, when they're going down into extension and it stretches and they get a pinching, very intense pain on the front of the knee, I often find that that is a joint problem. It's that the joint does not want to close down because of swelling, inflammation, or patellar mechanics. If the back of the knee is what's really giving them issues, I find that it is tightness and guarding of the posterior portion of the knee, hamstrings, calves, and the posterior capsule around the knee. So what do we do? If they are in a lot of pain, I have them just take something very small and I have them prop their heel up while they're laying down. Simple. It's about facilitating success for people. It's not about facilitating pain, because I mean their life's going to suck. They're not going to sleep well for like 4 to 6 weeks generally, in my opinion. So we're trying to facilitate success. So just sticking their leg out on something and putting weights on their knee, in my opinion, is a big no-no. I never do that, ever. I always start with their leg just propped up, no added weight, heel propped up, nothing underneath the knee, so gravity can start working on it, especially day one. So quick recap, home exercises are legs elevated ankle pumps to prevent clots in the calves and the ankles, short arc quads to facilitate neuromuscular control of the quads, and some improved knee extension actively. Knee flexion is going to be heel slides with a strap, most likely, or on a yoga ball if they have access to one. And lastly is to facilitate knee extension, I have them do heel propped, just relax. And I try to have them keep their heel propped up for at least 3 to 5 minutes, upwards of 10. Try to do that a few times each day or as they're able based on pain. And that's it for the home exercise program. As far as mobility, that's generally the last thing I do. I have them stand up and we talk about how they can now facilitate the things we are working on with both the interventions we did with the TENS or NMES and the home exercise program. How can they facilitate that as best they can with their walking? Oftentimes they have a walker. And what I like to focus on is even rhythmic steps. I like to have both. If the affected leg can only take small steps, I have patients do small steps on both sides. I have them focus on getting a good heel strike. And if they are able to tolerate full weight bearing on the leg, because a lot of people will just death grip and they'll get their hands on top of the walker and they are holding themselves up with their arms. As soon as they're able, I tell them to keep their hands on top of the handles like they would normally, but I ask them to start generating movement with the walker with the fingers that are on the bottom side of the walker. You're not lifting the walker. You are simply gliding it forwards with pressure underneath the handle from the fingers. But if the leg ever gives out, your hand is still very much on top of it, and they're able to quickly provide support from the top of the walker. And that is how we end the day. That is day one. I'm going to try to keep this under 30 minutes. We're right at 25 right now. So I'll tell you about step 2. So we'll call what just happened during the initial evaluation level 1. Level 2, there are a couple options. Patient has not changed, or patient is progressing well. And what does it mean that patient is progressing well? I like to see patients twice a week between their date of surgery and their 6 to 8 week follow up with their surgeon. What I consider progressing well is they're getting between 3 and 5 degrees of extension improvement per week. Again, most of the time, if we're sitting right around 10 to 15, even upwards of 20, that would give us at least 10 degrees of improvement and extension within 2 weeks, hopefully more. But if they're progressing well at about 5 degrees per week of extension and about 10 degrees a week of flexion, I consider that good progress. We're really looking for about a degree per day. So if someone is progressing well, how do I then facilitate more progress, and what am I doing in the clinic? The second session, when they come in, we measure their knee range of motion again. The second session is when I begin joint mobilizations. I like tibiofemoral joint mobilizations for both flexion and extension. I find that flexion mobilizations are best done, in my opinion, in hook lying for flexion, and I do unicondylar graded mobs. So essentially, it's a goodness. It is either a medial or a lateral condyle of the knee, posterior glide, and it's not aggressive. It's gentle. We're trying to just rock that joint a little bit into the range of stiffness, and just start to get the joint moving. For extension, there are 2 options. If someone is a little irritable, I will get their leg as straight as possible in supine. I'll prop just a little something under their knee, and then I will get my hand under the distal femur, and I'll try to get a gentle grasp on the distal femur, and then I will get my other hand on the proximal tibia, and I will try to gently facilitate medial or lateral condyle anterior glides. And if they're getting really close to full extension, I may even facilitate the screw home mechanism in that same position. If someone is more tolerant to extension, I get them prone, and I may put a little towel underneath their shin so that they don't have all the weight of their lower leg leveraging their knee while I'm trying to do joint mobilizations. But otherwise, I do a similar thing where from above, I get a hand on the distal femur and a hand on the proximal tibia, and I gently start doing one-sided anterior glides with them in prone, and that has been tremendously successful for me. I have gotten patients from lacking 12 degrees to lacking 4 or 5 degrees, and I would maybe say 30 seconds to a minute of mobilizations on each condyle. So that's what we do for hands-on things. I always continue to do NMES. So again, first session we did 10s, and we did as pulsed with the 2 hertz and the 200 width. After that first session, unless they're still very painful, I begin to transition them to NMES because we want to get that quad going. We want to normalize knee mechanics, and knee mechanics for walking require less than 5 degrees lacking of extension so that the quad and the knee aren't under additional thrust forces while walking. So I definitely do NMES starting session 2 unless someone is really lagging behind and painful, and I set it up the exact same way. 15 minutes, 5-second ramp, 10 seconds on, 45 seconds off, 50 hertz, and 300 pulse width. And I get something under their leg so that they can perform a short arc quad, and they're not going to get terminal knee extension. I'm just telling them to try and do a short arc quad to keep their heel off the table while the contraction is being facilitated with the NMES device. After that, second session, I get them on the bike for semicircles. I like it. I tell them that it should not be, we're not pushing to intense pain. We are mild maybe a little over mild discomfort or stretch, working back and forth rocking. We are not forcing anything. When the surgeon did the total knee, while this person was still unconscious, that surgeon grabbed the knee and he would have flexed it all the way and extended it all the way to make sure that the joint allowed the motion that he was expecting from the surgery. So it's not a matter of just manhandling things. It is more likely that the nervous system is restricting things and the body is trying to, again, accommodate the recent trauma. And so I'm just trying to facilitate some motion with pretty low level discomfort on the bike. After that, we don't change too much. If you have access to a total gym, I generally put it on level 2, 3, or 4 based on their tolerance. And I start doing some partial range of motion leg press with both legs. I don't do anything single leg yet. And we generally work through a few rounds of 10 to 15 based on their tolerance, or if you prefer time, a few rounds of 30 seconds to a minute. If your total gym has a calf raise attachment, I find it's really helpful to get some modified body weight calf raises done with the legs locked straight. They get to work on terminal knee extension as well as ankle range of motion and some gentle stretching when they're dorsiflexed during the calf raise. Otherwise, when we get to stretching, if they are in a bad spot, like they're not progressing super well, well, I guess let me rephrase that. It's about pain. If they are still super duper super painful, I still have them do heel props and heel slides to try to facilitate greater range of motion. After the first week, after those first 2 sessions, we will start to push because extension is so important. But if they're super painful, that second session coming to see you, I like to just stay with the same stuff of heel props and heel slides, give their body just a little more time to heal and start to figure out what the freak just happened before we go hard. If they're doing pretty well, maybe their extension is improving and their pain isn't terrible, they're in pretty good spirits, I like to do prone hangs. I don't do prone hangs with their whole knee and calf off the table, but I do have them lay on their stomach so that when their leg is extended, their feet are not on the table. And I will have them do that 10 minutes. But we're also going to work on knee flexion as well. So we'll do 1 minute with the leg down in a prone hang, and then I'll put a strap around their ankle and foot, and I'll do 1 minute with them doing a gentle knee flexion stretch. Again, it's not intensive at this point. I like to keep things gentle, but I tell them on the stretching portion of things that mild to moderate discomfort is okay as long as it doesn't make them significantly more painful later. The key after a total knee is repetition and consistency. If you try to manhandle this person's knee and it makes it very irritable, guess what they're not going to be able to do? They're not going to be able to do heel props. They're not going to be able to do heel slides. They're not going to be able to do short arc quads. At least they're not going to want to do them as often because they're simply in too much pain and discomfort. So these first 2 sessions, that's how I set them up. Again, recap, manual, I really like to look at tibiofemoral glides, hook lying for flexion, and you can do extension in supine, or if the pain isn't too bad, I like to do extension in prone. After that, we're going to do NMES with the parameters that I told you. And bonus fact for you, we have a red light device at the clinic. If you have a red light device, I love to put it on the knee. If it's a hard device, I like to hover it above the knee. If it's a wrappable device, so a softer to like wrap, and the knee is covered to where you're not going to put the wrap directly on an oozing, leaking, or bleeding incision, which shouldn't be happening right now anyways. If they have a strip of tape or something like that, I will put that red light wrap directly on their knee. If they've still got some scabbing or some oozing, I do not put a wrap on there because then we have to wash the red light, and it may be a pain in the butt to clean or sanitize or like that. But I like to, if you have access to it, put the red light on the leg if you know how to use it, and if you're comfortable with it. I like to do that for 15 minutes with the NMES. Nothing to lose, everything to gain by just facilitating improved mitochondrial function around the knee during that time. Okay, so I think that may be where we stop right now, because in my opinion, if you get a good start on total knees, especially in the first 2 or 3 weeks, you're going to do, I generally think they're going to do great. Statistically speaking, a surgeon can do a perfect surgery 100 times, and there will be a handful of people that are not going to get a good outcome. And that just kind of has to be handled. We kind of have to play it by ear when that happens. Oftentimes I find that the biggest thing to do when someone is not progressing well is do not catastrophize the situation. I think I'll end on this. There will be patients that come in. I have had this happen. I had a gentleman who was very active, very fit, and his knee was not responding well. His extension would not get past 10, no matter how much we mobilized the knee, no matter how much we did prone hangs. We even put weight on the ankle for prone hangs. And the knee flexion was not getting past 70. It just was not happening. We were mobilizing the crap out of it. We were icing it. We were trying to get inflammation out. We were trying to work it on the bike. We were trying to do some body weight bearing on the leg, because we were getting 4 weeks out and he was not hitting these mile marks that we were talking about. And you know what the answer is? There's a reason that a manipulation under anesthesia was invented. Sometimes this happens. But I have found if you're really making sure that they're getting consistent progress with extension and consistent progress with flexion, that people are generally going to do well. And if they're not, again, tell them up front. Sometimes, okay, organize my thoughts here before we finish. 2 things. If it's not getting better, you have to decide, is this not getting better because this person is not doing the things that I'm asking them to do? Or is this person not getting better despite doing everything that I'm asking them to do? If it is because they are not doing enough, sometimes you need to put the fear of God in them. You are a healthcare provider. You have every right to assert your position as an authority figure and say, here's the deal. We need to hit these markers. And if we don't, you are going to have to go back to your surgeon and they are going to have to put you under and manipulate your knee. And they'll be like, oh no, I don't want that. Well, you're damn right you don't want that. So it's like, you better start doing the things that I'm telling you to do. Don't chew them out. Don't swear at them. But you need to make sure they know that it is important that this thing happens, that they do the things you're telling them to do if they want to get better. If they are getting better, if they're doing everything that you tell them and it's just not coming along, it's very sad when that happens, because me personally, I get this feeling it's like this is not going well. If that's the case, I tell patients, listen, we are going to continue to work on the things we're working on. We're going to try to continue stretching. We're going to continue doing joint mobilizations. We're going to continue to facilitate improved muscular function through some exercise and NMES. And I just let them know, if we do not hit the markers that we are wanting to in the next couple weeks, you will likely need to talk to your surgeon and get back in to let them know how you're doing, because you may need a manipulation under anesthesia. And again, do it in a very positive light. If you've had previous patients that have had a manipulation, tell them how it went. I have had a lot of patients that have done very well if they needed a manipulation under anesthesia. So it's not a bad thing if it's needed. It's just important to accept that sometimes it is needed if we want to make these patients get better as quickly as possible. So those are my relatively quick tips for total knees. I would be more than happy to talk to anyone if you'd like to reach out to me. I'm at Perfecting PT on Instagram, or you can always shoot me an email at perfectingpt@gmail.com. And because I would love to start setting up I'd like to at least 2 or 3 times this year set up a group where we get a relatively large group. I think my streaming service allows for 10 people to be on screen at once and additional people to be watching a live feed and participate in the comments. I'd like to do kind of a comprehensive kind of overview and get lots of different opinions about how to treat different conditions and how to assess and how to plan prognosis. So if you would be interested, please reach out to me, or if you would like to come on the podcast and talk about things that you do practically that seem to provide good results, I would love to give you the opportunity to share that with people in this community. Last but not least, if you are someone who hates my guts, or you're someone who thinks that I'm an idiot, I won't use the R word. I'm not sure how many people listening to this will tolerate that yet. It's coming back. It's coming back, but sometimes people are bothered by that. But if you think I'm an idiot, please, I would love to reach out and have you on. We can even we could even set up a debate style podcast that doesn't bother me at all. Like I'm not opposed to being wrong. Because if I'm wrong, the faster I find out, the faster I get better. So I just hope you guys know, again, if you listen to this and you're still here, thank you so much. Thank you for spending part of your day listening to me. Like it actually makes me emotional to think that people take time out of their very busy day. I know you got shit going on in your life. I know you're trying to figure out student loans. I know you're trying to figure out your families. I know you're trying to figure out what you're doing with your life, and to take some time to spend with me, I'm incredibly appreciative. So, thank you, friends, for being with me today. And again, if I can help you with anything at all, feel free to reach out. And I'll talk to you next time. Take care, guys.